So, welcome back, everybody, to part 2 of the AVH case-taking series that Dr. Beal is kindly leading for us. But tonight you'll have a chance to ask questions about the last one, as well as Dr. Beal will do a quick review. But again, we're here mainly for you guys. Any newbies, please ask any questions, cases, whatever, interpretation that we can help you with. So without further ado, let's go to our review by Dr. Beal.
Hey guys, I'm just looking at the attendees list and trying to figure out who was here last time and who wasn't here last time. But wanted to continue our discussion about case taking by first of all summarizing what we talked about last time, and the biggest thing I find is that we want to make sure that we understand that actually the folks that wrote way back when, it was actually Kant that wrote it in his writings, that talked about a well-taken case is a case half cured. And the other thing that I really have found it helpful over the years and want to emphasize to folks is that importance of trusting the client, because they know their animal the best. They may not have all the fancy words and the terms and that sort of things, but they actually know that animal. I'm gonna throw my slides up from last presentation as we just go through them fairly quickly. Anytime anybody wants to stop or ask any questions or make any comments, just raise your hand, and Jeff is wrangling that stuff. So I'm going to just put this. I'm just going to put my screen up and let you show that, or let me show that to you. So as I say, we talked last time about that whole business, about this whole process is actually a remembering, and as I was saying, to trust the client and let them tell the story. As again, they may not have all the fancy words or the quote diagnostic label type stuff, but they really do know their animals. And one of the things that I have found that has steered me away over the years from doing a questionnaire type of analysis is the fact that when people get asked questions that are out of the clinician's imagination about what they want to know or think they need to know, a couple of things happens. One is people stew about it and worry and do all of that sort of stuff. But the other thing, and more significantly, is that you don't get the use of the client's spontaneous words. And the other thing that you don't get is the priority of things that are up for the client or the caregiver. And those things can be really, really helpful. I find a lot of times the way people use words and the patterns that they use and the words that they use to describe things in conversation can be remarkable, actually, again, for prioritizing stuff, but also for being descriptive and getting an emotional sense of that. And one of the things that we try to do a lot in homeopathy, it seems to me, is to humanize the art and science. And so, well, part of the work that we do is to look at lots of picky things and sort of little bits of points of stuff. I always remember that we're taking those points to make a larger picture. And one of the things that happens a lot of times is that we end up in a relationship where there seems to be some divergence of thought and thought process and that sort of thing. And there are some situations, where it can really polarize things with, the client being at the inquisition with the clinician. And I really try not to do that. The other thing that we talked about was how do we create an environment that's conducive to doing this work? And I think that's really important. For those of you who are in the midst of struggling about how do we take a conventional practice and switch it over to paying attention to homeopathy more seriously and for a larger proportion of our practice, um, we really know that it's really hard to get cadence and rhythm of case taking, and also the conversation and the time in the office with folks in a regular office call. It's hard actually to do even the basic background stuff of doing the little bit of explaining and the scenario stuff and all of the other things that get um, uh, inaccurately called homeopathy, but we do as clinicians. They actually are part of the whole larger art and science, but that we do as clinicians. When we start talking about how do we allow naturally occurring symptoms to actually articulate, and how do we remove obstacles to both the articulation of those symptoms and also obstacles to the ability of the individual to respond to the remedy. So what I found over the years, and one thing that's worked really well for me, I historically have done a lot of work over the telephone. I don't work with everybody over the phone. I pick those clients rather thoughtfully, but I have done a lot of work over the phone in the years. I understand that there's people here that don't like that, aren't comfortable with that. Some people think it's a travesty. I'm not here to debate that right now. But one of the things that I have found is that even for clients who are geographically approximate to me, and in some of my practices that would be from 2 to 6 hours away, is a relatively geographically approximate client. um, that even those people that would come to the office for conversation and physical examination and all of that sort of stuff, the actual intake, the anamnesis, the remembering, we always did it on the phone. And what I found happens when that happens is that it gives me as a clinician the ability to set aside time and space for that, and it gives the client ability to set aside time and space for that, and you don't have all of the distractions that we all know are possible, of even simple things like phones ringing and stuff crashing around in the waiting room and or reception area or whatever we're calling that now. And if you have animals in house and other clients, or if you're in a multi-person practice where people are doing several things at once. That I found has been really, really helpful. The other thing that we talked about was actually the structure of the process, about listening, letting the story be told, clarifying any comments or questions or stuff after the story is told. And then what I found useful for me is doing that physical exam over the phone, no detail, do they now or have they ever, and literally going through all the symptoms. One of the things that we find as we hone our craft is that we become more aware of the significance of seemingly simple symptoms or stuff that we have ignored in the past or never recognized as one of those subtle symptoms of chronic disease. And we've also familiarized ourselves more with the repertory as well. And so that we know what kind of rubrics are in there, we know what kind of sub-rubrics are in there, we know that, geez, the last however many cases that I worked, I was looking for information about this particular symptom, and there were these differentiating sub-rubrics, and boy, wouldn't it be handy if I would differentiate those things before I hang up the phone or before the client leaves the office, or however that works. And so that's really helpful. The other thing for me, and again, I know this doesn't work for everybody. Some people like working on the computer and taking notes on the computer while they're taking an intake. I find that that's not very helpful for me. I do a lot of writing on the computer. I do a lot of correspondence on the computer, but I find when I'm doing an intake, I actually take paper notes and arrange them in the case folder records in a way that I can differentiate the intake from the rest of the case notes. I actually tend to color code things a lot, and that's been pretty helpful. But part of the thing about wanting to say, and I said that earlier, is the ability to write things down verbatim, exactly what comes out of the client's mouth, and it's a skill that you can develop, and it for me, it works more simply if stuff just goes in my ear and out my arm rather than on through the keyboard. And I also have some real short forms in my notes that I use to differentiate whether I've asked the question or whether it's a spontaneous declaration or whether it's a particularly significant quote. And so I use a series of question marks and brackets and those sorts of things. I'm happy to share that. I'm happy to share that with people if they're interested in that. But it helps me when I go back over the notes so that I can make some assessment about things that people said, and it also helps me in the follow up as well. It helps when I'm sharing cases with people. It helps when I'm doing cases for teaching and that sort of stuff, because it also gives a sense of the flow of things. The other thing, and just to remember and to remind us, is that we really don't have to talk that much. Mostly we don't want to interrupt things. Mostly we want to interrupt with very small prodding stuff, how so? One of the big things that I see a lot in clinicians over the years, and folks that I mentor, and other stuff that's come up both on the professional course list and other lists, is that whole question about diagnostic labels. So I'll see a history that'll come back and it'll say an ear infection, or it'll say parvo, or it'll say heart failure, or it'll say whatever the diagnostic label is. And my question is always, how did they show that? Oh, I took him to the vet because he had an ear infection, or you know, what was he doing that made you feel that he needed to see the vet? Or, well, the vet said he had an ear infection. Well, what was he doing that caused that diagnostic label to be? So that's going to give you way more information than ear infections, because really they don't exactly exist. Those are animals who have symptoms in their ears. So we talked about that, and again, the point, and I'm waving my hand at the slide on the screen that says, then for me, I'll skim the medical records before I see a case, but I don't sit and ponder and ponder and ponder and ponder and ponder over them. But what I see and have seen over the last 20, 25 years is that if we lead with the medical records and are light on doing the actual anamnesis with the client, we're going to get ourselves down a rabbit hole, first of all, and we're not going to have really great information. And what I tend to see is that conversation with the client tends to be more polarized, and it tends to be more inquisitional sometimes, in that you're flipping through medical records and trying to remind people of stuff that they may or may not remember, or they may or may not remember the language, or whatever. The other thing that I don't do when I'm case taking is I don't do a lot of explanation about homeopathy land. I don't do a lot of explanation about the philosophy of homeopathy. I don't do a lot of explanation about any other stuff. What kind of diet they should be on, any ancillary therapies that you might be doing. I do very few, but I do some hands-on body work, either chiropractic care or craniosacral therapy. But I don't have any of that discussion there, because what happens is folks get all the H words confused, and so they forget about holistic and homeopathic and those things, and they get supplements confused with homeopathy and stuff. And yes, arguably, in the larger umbrella of the art and science of homeopathy, those things are significant. Um, the discussion of appropriate diet, the discussion of appropriate lifestyle, the discussion of appropriate supplements, and those kinds of things. But people get all muddled up. So I try and separate those things as much as possible, so that we actually have dedicated the time that we have for the actual anamnesis. So then
I was
I'm
just
just
going
gonna,
to interrupt if I may, because if I can share my experiences, because I do treat a ton of really advanced cases, and I find personally that there's a direct proportion between what Sue said as far as balancing the medical records during the exam, during the intake, and just letting them flow. I find that a lot of the advanced pathologies don't have a lot of background. Most of it is from the medical records when you remind them about the ear infections that had 3 times a year, or this or that, or all the visits that they've made. That can really round out your case. And a lot of
yes. Right. And I also find that that physical exam over the phone
mm,
does that. I went through a period in my practice, and I think I've said this to some of you, that for a couple of years, probably 95% of my caseload was stuff of some sort of cancer. And probably 3% of my caseload was serious life-threatening disease of some other thing, maybe kidney failure or heart failure or epilepsy or something like that. And 2% was, quote, easier, whatever, less scary diagnostic label stuff. Not easier necessarily, but one of the things that I found was that physical exam over the phone was helpful. And the other thing that it did was, it when people show up with a big scary label diagnosis, they're all excited about the big scary label diagnosis, and every other clinician that they've seen along the road is all excited, because they go oftentimes from a general practitioner to a more specialized specialist to a more specialized specialist, and they go down the rabbit hole of reductionist medicine, when we're trying to get them out of that reductionist medicine rabbit hole and start talking about vitalists and vitalism, and that larger picture stuff. And so it's really important that you can't blow off a serious label diagnosis, but you also can't make that the biggest thing in the room. And we always have to remember that there's an individual and a history, and a whole thing attached to that scary label diagnosis. And so I encourage folks. I mean, I certainly encourage folks to talk about that, but I also encourage folks to um, what preceded that. And as Jeff said, folks tend to forget that sort of stuff. But honestly, I'm trying to think of the number of cases that I've seen over the years where I've had a truly one-sided case. And I probably could count those cases on the fingers of one hand. One dog I remember had a brain tumor, a big it was a big sinus kind of tumor thing, and that dog did not. We could not elicit at all, either through medical records or conversations or anything, any other symptoms in this dog. No behavioral stuff. No, it was really interesting. But these one-sided cases, yes, there's a lot of these one-sided cases are not as common as people think they are. Sometimes we have a case that's not well taken. Sometimes we have a case where the client's distracted and forgets about other things. But I think it's part of our job is to figure out what's the best way to literally seduce that information out. And the medical records can be helpful to remind folks of stuff, but I don't think that it needs to be argumentative. And I think that I see a lot of times that the diagnostic label on the medical records then gets translated into a symptom, and that's prescribing on penultimate pathology is not always very rewarding.
and
Any other?
yeah, I'm
Oh,
gonna ask a question here or make a comment before questions in that. Yes, everything Sue said is so true, but I find that it really pays and really is important to up front, educate your clients to the difference between energetic abnormalities and homeopathy and an H word and physiology, and point out as you go through the records, if you go through the records, that this is a label diagnosis, but what were the symptoms? And by looking at it from vitality and balance instead of physiologic secondary changes, most people grasp it pretty well, and they help you a lot during the case taking. And in ensuing months, they become your partners, and they really intuitively and commonsensically understand how their animals are getting sick.
I agree, Jeff. And I think you and I are saying the same thing in sort of different words. How did they show that? I think also when we talk about like dynamic derangement versus other derangement, we do see derangement, for example, from errors in diet. I was talking to a colleague the other week, and she had a dog that primary presentation was a bunch of skin stuff and some other things, but primary presentation was 8 years of chronic skin disease, diagnostic labeled chronic skin disease stuff, and certainly had a lot of other things to prescribe on. But just doing some simple stuff like making some modifications in the diet totally changed the appearance of symptoms, actually started allowing the dog to generate some modalities and that sort of stuff. That is not, I'm going to that is not dynamic disease the way we think about it in homeopathy land. I personally think it's dynamic because everything works out to be energy with me in some ways. So yeah, there's certain dynamism with that stuff in our relationship with food and how food acts and the quality of our food and that sort of thing. But we need to be able to differentiate that. I think the bigger thing that Jeff said, and I think the thing that we see as clinicians, and we see it, in my opinion, oftentimes more clearly the longer we hold this role, is that we do see this really amazing relationship with our clients, and it's at a different level than when we were, back. It's different than when in our conventional veterinary practice. To me, it seems a little deeper. Yes, our conventional clients may love us; they think we're wonderful or not. We do. It's more of a doing process, though. Oh, thank you so much because you did this, or thank you so much because you fixed that, or whatever. I think what's been true for me as my practice changed, from back in the day to 20-25 years of the kind of practice that I have now, is that there is a deeper working relationship with our clients, and they learn to trust themselves in a way that they've never been allowed to trust themselves in most other relationships with clinicians. They learn to trust their impressions. They learn that not that veterinarians don't take their clients seriously, but that they learn that we take them seriously, and it's not that placating. Oh no, don't worry, Mrs. Smith, that's fine. If you're worried about Fifi, bring her in. It's not like that. It's actually in a deeper sort of fundamental stuff, and they have authority as observers. They have authority as co-creators of the whole system. It's very interesting to see what happens, and they're much more an active participant in the whole process than they were rather a consumer of medical stuff. And um, you know the looking, I mean, the whole terrain has changed, when we look at what kind of information is available to clients that wasn't available even 10 years ago. When we look at how to filter out the quote good stuff from the bad stuff, the wheat from the chaff, and all of that available information. But the process I've found is much more collaborative generally. What I see happening in new clinicians, either new grads or new homeopaths who are still. I mean, we all come to this for a reason, you know. We come because there was something that was missing, even if we didn't know what it was that was missing in life before homeopathy or medicine before homeopathy, or however you want to say that, um, and or practice before homeopathy or whatever. So the thing that sends us down that trail, yes, granted, there's some people that want to gather up certifications the same way somebody would gather up, you know, charms on a charm bracelet. But really, the driving force is that there's something else, something else. We don't know what it is. We're looking, we're looking, we're looking. But as we make that transition, it's hard to be a student and have an understanding about something, even if we're really excited about it, and then allow that to be just comfortable enough in the process. You know, it's kind of like when you're learning to do anything. You know, when you're out driving a vehicle, you know, you're trying to put all the parts together and see how it works instead of just going down the road and shifting gears. And I see that's, you know, that's part of the difficulty that I see, you know, when we're new to the art and science, and that whole business of, you know, trusting the process, trusting the client, not getting into sort of rote ways of doing things, and still being able to kind of steer the boat or drive the bus is usually what I say. Anyway, anybody else have anything to add to that? You can just there's a thing on your little control panel that lets you raise your hand. If you want to raise your hand for those folks who aren't muted. Anybody else on the panel who has anything to add uh, before we before we?
Okay.
I have
Jane,
another question. I have another question after this, and then we'll move on.
Jane, Sarah, anything to add? Laura,
What?
to any of any, any of you guys have anything to add?
No, this is good.
I'm really interested at I can't see who all is on the attendees, but for the folks who are relatively new to the craft, and also for the folks who have, I don't have my list in front of me about who was on the webinar last time. I have two questions. One is, are you seeing, what kind of difficulties are you seeing in your practice, and do you think that some of those difficulties might be related to the manner in which your information is gathered? And for the folks who might have been here last month, have any of you gone back in the clinics and amended your information gathering, your anamnesis, to look at some of the things that we talked about last time? And Jeff may be able to just open the mic up for everybody to speak freely. That's not going to work if somebody's you know, tending a kennel full of bloodhounds or
Yeah, no,
juicing or something like that. But we can try it. We can try it and see.
okay, let's see. So Ela is unmuted. Karen, looks like you're not connected to audio, but if you enter your PIN #57 pound, it'll reconnect. Laura, you're unmuted. Oh, sorry, Rachel, and oops, and Stephanie just joined us. Okay,
Okay.
everyone's unmuted.
Yeah, so I just wondered, you know, if there's any questions or comments about last month's webinar or some of the things that we've said so far before we go off down another, not tangent, but another part of case taking consideration.
I wasn't here last month. This is Jane. But
Hi, Jane.
hi. I found that this conversation right now is helpful because of you're talking about helping people to understand the difference between a name diagnosis and what's actually happening. And
Yes.
like my Cushing case, they always want to say they have Cushing's. You know, it's something about Cushing's that they've just got to embrace it. But you know, I treat them anyway, and if things if they go several months without needing a remedy, and then symptoms start coming back, it's like, oh, they've got Cushing's again.
Yeah. Yeah, and you know, and I think and you did this, and I'm not calling you out, but I'm going to use it as a great example, and we do this all the time. Is, you know, it's Fifi the Cushing's case. No, it's not Fifi the Cushing's case. You know, it's Fifi, a dog that might present with Cushing's or something. And we do this as clinicians all the time. It's easy. I mean, we categorize stuff that way, and we make the disease, the diagnostic label, more important than the individual. And as soon as we do that, we're cooked. You
Well,
know,
100% of the cases that I've seen that were labeled as Cushing's, I didn't make that diagnosis.
yeah, no argument there.
The thing to say would be presented with supposedly Cushing's or whatever. Yeah.
Right. I can remember filling out I didn't have a lot of people with pet insurance, but I did have a few, and I can remember the first pet insurance form that I ever filled out. Oh my God, however many years ago it was, and I actually wrote, you know, what was the diagnosis, and there was room for you know, holistic or integrative or whatever the heck it was. I mean, everything was kind of like officially billable, but I actually, you know, their diagnosis at what did they want, and so I wrote, you know, an imbalance of the vital force manifest as diagnostic label A, diagnostic label B, diagnostic label C. And that's the way I wrote it. I thought, yeah, it takes a lot more words, but we need to, I think, we need to, we need to remind ourselves, those of us who've got some calluses on our butt from being in this saddle for a while, and the folks who are new to the trenches, you know, we need to remind ourselves that as soon as we focus on the disease label, we're cooked. We can use that thing, you know, we can use it for lots of reasons. We can, you know, we can use it to talk about how do they articulate those symptoms. We can use it to say that, you know, if somebody comes in with a disease label of something that's deep in the meat and structural, they probably have a different vitality, different response to previous treatments, those sorts of stuff, than something that comes with stuff that's superficial and not structural. So I'm not saying totally ignore that, but I found over the years, you know, I've actually had to write a little note on the way my charts are. I have a place for the signalement and the address and all that nonsense, and I actually have to write a little note about what the presenting complaint is, because usually after 4 to 6 months of working, the clients as well as the clinician forget what that is. Anybody else got anything to add? So one of the things that I think is really interesting about homeopathy, and about looking at homeopathy, is that we look at patterns, and we tend to get lost in the weeds of the individual points rather than just looking at the overall pattern. And so we get tricked, first of all, and secondly, we miss patterns. And I always, for those of you who really know me well, you know that I'm facial, and I'm really kind of, I see stuff in my head, you know, wandering around. So when I look at cases, it reminds me of like a quilt or a contra dance, where we have patterns and flow and things that happen in physical space over linear time. And I start looking at the three dimensionalities of, or not even three, the multidimensionalities of disease and disease progression. And one of the things that we forget about when we talk about this is that it all happens over time. So it's not just a moment in space, but it's actually a presentation over time. So we're looking at a moment in space, but we're seeing it through our over time goggles, however you want to wrap your head around what I'm trying to explain. And that's one of the things that folks tend to, it's hard to conceptualize, like what's a early belladonna state look like versus a mature belladonna state, those sorts of things, or how has the overall imbalance, because we know that disease is a holographic thing, that you can't just have disease from the homeopath standpoint, that imbalance of the vital force, that dynamic thing. We can't just have it in an ear. As soon as it touches the individual, as soon as the individual has disease, the whole individual is diseased, even if those symptoms are not manifest in all the bits and pieces and parts of the whole individual. And being able to understand that, and being able to look at how does that larger thing work as a whole individual pattern versus discrete, unique symptoms, it can be useful sometimes. It can be useful a lot of times. So I know I've used this example before in other conversations, but if we have an individual that has green stuff coming out of the ears and the nose and the eyes and the vulva, maybe the ears and the nose and the eyes and the vulva aren't as important as the fact of the green stuff. So that larger pattern of, boy, he likes to make discharges and they're green, that's more useful in the bigger picture than, oh, he's got ear discharges, or he's got eye discharges, or he's got vulvar discharges, or whatever. So we start to look at patterns and commonalities. Do they have responses that might, they respond in a certain way to a certain circumstance? Are there other similar circumstances that might create, engender the same or a similar response? And so then we can start piecing together, instead of the picture, and I should have got one to put up on the screen, but that picture of sort of, the pointillism art, where you have little point, and we take a step back, and my gosh, we see there's this phenomenal picture showing in front of us.
That's
So
the blind man and the elephant.
exactly. So we looked around these whole symptoms to repertorize. It could be really useful to zoom through these quickly. If we need to slow down and zoom through them more slowly, I'm really happy to do that. I'm really happy to do that as well. So we know that choosing rubrics and rating symptoms are important, and we know that the hierarchies of these symptoms can be really important as well. And so one of the things that we see happening is that we need to start making some decisions as a clinician about what we're going to talk about and what we're not going to talk about. And we need to start making some decisions, as I said, earlier in the hour, about what is a symptom of the naturally occurring disease versus what is a symptom of the modified disease because, they're on supplement X, or they're on a restrictive diet Y, or they're on, some commercial dog food that's got lots of salt and sugar and high fructose corn syrup in it. And so it doesn't do us a lot of good to dispense on symptoms that are not symptoms of the naturally occurring disease. It doesn't do us a lot of good because we're tricked, and it doesn't do us a lot of good because we're actually not doing what we can do to help restore the individual to health. And what happens when we're prescribing on those kinds of symptoms is that we get really confused cases. And one of the hardest confusions, ways to confuse a case, I found in my experience, is to have a situation where somebody has had lots and lots, or even lots and lots of remedy, and that hasn't had those can be tough cases, where they've kicked they've kicked the headlight symptom down the road, and then they've kicked the bumper symptom down the road, and then they've kicked the grill symptom down the road and the rear view mirror symptom down the road, but they've never kicked the whole truck down the road. Those can be really, really hard cases to get back, just because of the influence on the vitality of the individual. So I think it's really important that we differentiate the symptoms of the naturally occurring disease from the symptoms of the adulterated naturally occurring disease. And what that means a lot of times, and I don't think that we need to be shy about doing this as clinicians, but what that means a lot of times is when somebody comes in to see us expecting that they've gone to see Jeff for homeopathy land stuff, and they expect him to give, drops or pellets or whatever they expect him to do. A lot of times, the best thing you can do is actually take a step back, look at dietary stuff, and to me, somebody says, oh, they're on real food or they're on a fresh food diet. That doesn't mean anything to me. You got to tell me what they're eating, how much they're eating, where's it from, how are they preparing it. We've got to look at the supplements they're on or not on. We've got to look at also the other medications that they're on. And I'm not of the school that necessarily wants to have somebody totally medication free before I start treating, because a lot of time that is warming up for a lot of difficulties, which I'm happy to discuss. But sometimes we find medications that folks are on that we can back up. Sometimes we underestimate the power of safe supplements and those sorts of things to palliate disease in a really strong way. And the other thing is that we've got to back stuff up enough so that we know where that symptom is. And some stuff we back it up really a lot, and the symptom's been, the vitality is such that the symptom has been scared into submission and it ain't coming out for anybody. But other times you can back some of the supplements, and I see this a lot with joint supplements, for example. You can back them off a little bit, and they'll start to limp or be a little uncomfortable or whatever. And I'm not saying that they need to limp and be uncomfortable all the time, but we need to understand the power of those supplements or those other treatments. A lot of clinicians, a lot of clients, well, no, back up. A lot of clinicians juggle a lot of different therapies out of their office all at the same time. So they're having acupuncture for this or laser for that or whatever. And oh, by the way, we're doing some homeopathy too. So recognizing how to realize and recognize the influence of those other therapies on your pure homeopathy case, but also realizing that a lot of all of these medications do have that influence. The other thing that we talked about, and we've talked about all the time, is not prescribing on common symptoms or symptoms that describe pathology. So if we've got a case that is only talking about headache or only talking about seizure or only talking about that's a pretty wobbly stool with one leg under it. The other thing that, if we've got a symptom or an individual, where we've got a diagnostic label of heart failure, for example, maybe the coughing at night or the exercise intolerance or the pale mucous membranes or the slow capillary refill or the panting is not really that significant a symptom, because those things can all be very common symptoms of congestive heart failure. And so what we need to look at, same with this example I use all the time, the cats and kidney failure, they're skinny, they pee a lot and they drink a lot. And that doesn't necessarily tell us anything about that individual cat. And so the thing that we need to remember all the time, but particularly when we're at the cusp of getting tricked to prescribing on common symptoms or symptoms of the common symptoms of the pathology, is what is it that differentiates this individual from every other individual that I've ever seen with congestive heart failure? Those are the things that are going to be that really important stuff that are going to build meat. Don't make stuff up. And don't prescribe it on certain stuff, and don't prescribe on stuff you're assuming or presuming, that every dog in rescue got beaten by some guy with a baseball cap on, or whatever those things are. Yes, those things are those. I use a lot of mental and emotional symptoms. Some of my colleagues don't use as many as I do, but if they're true and honest, and you're not making stuff up, then I think it's reasonable to do that. I think it's reasonable to sort of have a section on the right-hand side of your page when you're writing your reports that talks about, is it because of this, or, you've got this kind of differential thing about, is it training, or if they get scared, or dot, 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 dot. But don't be making stuff up. The other thing, and again, we said this before, but that whole thing about what the symptoms doing today after, 3 laser treatments, 4 prescriptions of antibiotics, a bunch of non-steroidals, 6 supplements, and 2 ear washes, and some weird special hood with magnets in it, is not going to really be the symptom, So we can do a lot of work in a lot of positive ways by going back and looking at what that symptom looked like originally. Sometimes we really luck in and we end up with a situation where we have, to use my earlier example, we have an immature belladonna state in 2002, and we have a more mature belladonna state in 2004. And actually the individual has never changed remedy states, but it's just gotten into a deeper articulation, a more mature state of the same remedy. Sometimes that happens, and sometimes we can get that information when we look at the original symptoms. But those chronic cases, this goes without saying, but I'm going to say it again because it happens to be here. Just because it happens or is always present in an individual or in a breed doesn't mean that it's normal. So we've got to be really, careful with that. I'm going to just flip through this real quick. And again, stick your hands up or shout out or something if anybody's got something that they want to contribute. These are a couple of different hierarchies of symptoms. They're not standalone. You can put them together in multidimensional ways. But these have been really helpful to me over the years at looking at things that gives us a way that you've got this individual and they've, you've just spent an hour and a half on the phone with them. You've listened to what they've talked about. You've reviewed the medical records. You've asked the questions that are clarifying. You've done the physical exam over the phone in case somebody missed something. And the last thing that I always do is ask somebody to describe them, and they'll give you 6 points, and your case is usually in those 6 points. But once you got all that stuff, how do you sort it out? And so that whole question looks at this hierarchy. This was gathered over the years from a bunch of different sources. But we look at, I'm just trying to think, some of it's Julian Winston's old work, some of it's Will Taylor's old work, some of it's some stuff that I created on my own, some of it's I'd have to think back about. Hal Williams actually put some of this stuff together too. So we look at the peculiars, we look at the mentals, we look at the generals, and when we look at the generals, the things that the hierarchy, the sub-hierarchy under the generals is rubrics from generalities, rubrics that influence the whole patient, not just a symptom in one corner of the patient. The sleep modalities are very, very significant. And I think there's a lot of stuff that we can get from our animal patients in sleep that get missed. A lot of times folks never ask about sleep. Where do they sleep? Do they sleep through the night? Do they put themselves to bed at the same time every night? Or do they wait till the owners go up to bed or over to bed or whatever direction that is? Do they wake up in the morning? Do they wake up with the owner, or because they're not done sleeping, but they're more driven to go with the owner? If you were going to sleep in, what would the animal do? That sort of stuff. That there's a really sweet rubric about indisposed to rise. It's been a very useful rubric to me over the years as well. So again, in that hierarchy of generals, the food aversions and desires can be really significant, particularly if it's been a change over time. When we look at menses, one of the two first things that go when bodies are not running on all cylinders in free and fluid motion, the things that go first are our sleep-wake cycles and our reproductive cycles, and it's a really big thing that unfortunately, when we're talking about companion animals, that stuff is sometimes removed because we're doing a lot of early spay neuters, or animals, are being spayed or neutered before they ever come into reproductive maturity, that sort of stuff. I see it a lot in my farm animal and horse stuff, is, looking at heat cycles and that restoration of normal menses and normal cyclical menses. And that's really, really, really important. And that whole business, it's normal in this breed to have 11-month menses. I'm here to tell you, I've not seen a breed that's normal in, because when we treat those breeds, and we see a menses return or a heat cycle return to more species appropriate, after that tells me that we've got a whole lot of chronic disease out there in those particular breeds. Sexual behaviors are really important. Things like regular type of sexual behaviors, interest or disinterest or whatever, but also stuff that gets called sexual behaviors that I believe is not always sexual, sometimes has influence by rabies miasm, in my opinion, and experience. Humping behaviors, erections in neutered male dogs, sexual interest in male or female, whatever of the species, those kinds of things can be. And yes, some people will say, well, that may be behavioral dominance. It may be perfectly normal when you get a group of puppies together to have this dog hump that dog, and certainly some of that is within the realms of species appropriate behavior, but sometimes it isn't, and we need to watch that. Body type, there's a lot of people that talk about not prescribing on body type, and I can dance both sides of the road for that. Sometimes we'll see some facial expression stuff that can be particularly useful if you're prescribing for humans. And the other thing that is really useful to me, I find, is modalities. What makes things better or worse? And we then going down that whole hierarchy from the upper points, then local physicals are less significant. Modalities to local physicals are lower on that hierarchy. I'm not saying don't ever use them or not to use them. I'm just saying that I put more weight in those bigger things that describe the whole bus, rather than the thing that describes the broken headlight, even though the bus was presented for a broken headlight. Going on to peculiars, etiology to me is really important and significant. And one of the things, we have a whole ailments from section, and we can get all sorts of things. It's really interesting and easy to be overly anthropomorphic. It is possible to be appropriately anthropomorphic and to use those. The thing that we have to make sure when we're using those ailments from is there's actually an ailment from them. And so just because the individual got antibiotics or had a steroid or had a vaccination or had something that folks might not agree with happening, doesn't necessarily mean that in that animal or individual that it made an ailment from that. It may have eroded the vitality. It may have been a non-curative choice of therapeutic intervention, But in and of itself, it doesn't necessarily mean that non-curative therapeutic intervention was applied and ailment X arose. So I see a lot of times where folks say, ailments from vaccinations, it's that are not accurate, or ailments from use of antibiotics, and that they're not necessarily accurate. And so I would encourage us not to be tricked by that. The suppression of eruptions and discharges and menses, those things can be really significant. But one of the things that we need to remember again is if you've been using ear stuff in an ear, maybe not the best example, but I'm going to go down the trail because I started. If you've been using ear stuff in the ear and the ear is still having discharges, then you haven't got a suppressed ear eruption, or an ear discharge. If you have a situation where you put stuff in the ear and the ear looks beautiful, and 6 weeks later the dog has a seizure, now we're talking. Even if 4 weeks after the seizure, now the ear starts to discharge again. Now we might be able to have a fairly significant conversation about suppression of discharges and ailments from. But don't presume just because somebody's been on ear medication for days, weeks, months, that we have a suppression of discharges. And I see folks get tricked with that a lot. Keynotes, we could probably talk, and I actually think that somewhere in our archives we do have I want to say Kim Elia did it, a presentation a number of years ago on keynotes, where we're talking in symptoms where there's only a couple of remedies listed in the repertory. But the trick is, that symptom's got to be important to the case. It's got to be central and characteristic. These other ones, you can read them as fast as I can talk about them. Those alternating symptoms, those periodic symptoms. Periodic symptoms, we need to check with those. We see a lot of situations where folks don't recognize periodicity. Stuff happens off and on, every now and then, can't figure it out. He's good for a while, he's bad for a while, bop, bop, bop. I encourage people to write stuff down on the calendar. And once we start looking at that, oftentimes it's very possible to see some periodicity. Again, vicarious symptoms we don't often see in animals. Extensions, it's really hard to even deal with in animals. They're really, really great in humans. For those of you who are prescribing in a non-speciated situation, and the sensations, if you've got an accurate feels like, that can be very, very, very accurate or very helpful. The number 9, that expected symptom is missing. They're quite frequent and they're very helpful. And a lot of times you'll see them at that early case. Remember when I said to go back and look for the symptom before it was adulterated and fooled with and mashed around? A lot of times you'll see that expected symptom is missing. It's much more reliable there than if you've got that, bald, red, itching dog that's been through all sorts of stuff. Mental characterizations of as if, it feels as if I've got a knitting needle stuck in my ear. And stranger and peculiars are great. If they're there, they're beautiful. I'm gonna come up for air for a minute, and I want to say something. I recognize we're right on the cusp of 9 o'clock, and so before I close this, I'm happy to continue on if folks have questions. There's a couple more points that that we talked about last time, just differentiating. Excuse me. How do you do case situations where you really can't get a full case? How in my practice, my approach to doing herd animals and some situations of farm animal stuff differentiates a little bit from how I might deal with dogs and cats and stuff. But one of the things that I really, really want to encourage folks to do in their medical records is, when you get to the end of a conversation with a client, I want you to really make a commitment to writing an assessment and a plan. And when I coach people about this, what I find happening is people write an assessment. An assessment is just a regurgitation or reiteration of a clinical observation, and that should be up there, up further in the records, that this is a clinical observation. But I really encourage you to write the assessment. What is it? An apparent appropriate direction of response, an exteriorization of symptoms into the left ear, a return of an old symptom into the limping. I wonder if the remedy is waning, the response to remedy is waning because we're seeing intermittent return of chasing groundhogs. Whatever that is, and that'll do a couple of things. One, it'll help you make sure that your thought processes are actually happening, that you've actually done the information gathering, and now you've actually made an assessment. And those two things are not all mashed up all together, all in one thing, without any periods or time to breathe. So that does that. The other thing that it does is it really makes your case review really, really much more simple, because you can flip through a whole bunch of reports, and if you've got that clear assessment there, it gives you some sense of which direction things are moving in, and you don't have to go back and read the whole rigmarole of records and stuff to sort it out. One of the things you'll find as you build that relationship with your clients that Jeff was talking about, that sort of co-creative thing that happens when we're working this way with people over time, is that also the clients can also start making an assessment as well. That doesn't mean you have to agree with one another all of the time, but it's something to do. The other thing that I encourage folks to do is at the end of your page, or your typing, or your writing, however you're doing it, you've got an assessment, and you've got a P for plans, and they need to be clear plans. Wait, repeat the remedy with the potency, whatever it is. Call the chiropractor and book in an appointment.
And
Decrease whatever.
that's a really, really useful place to write down your thoughts about what the other remedies that could be indicated based on the info that you just, sat through, listened to, put together.
Exactly. And your assessment could be that he's warming up for a change in remedy, but the direction is not clear. The plan is, observe symptom
Repeat.
X, report, repeat the remedy. But you should be able to go through your medical records and summarize the case, not with giving me a laundry list of all the symptoms, blah, 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 but summarize the case that said, this is what happened. This was maybe the response, but here's the assessment, here's the plan. And I will guarantee you that your understanding of what's going on in the case, and sometimes the assessment is, I don't have a flippin' idea what's going on, and I'm going to run them a little bit more rope, and they can call me in 2 weeks or sooner if something changes. And that's a perfectly valid assessment. But I guarantee you that your case management is going to benefit from this, and I guarantee you that your ability to, when you have to go back and flip over records, when you're paging through the records, when they come in for a recheck, it's gonna help you a lot.
And
with
it's
that,
using a part of your brain that has been already so well trained in vet school. The soap procedure, or soap
yeah.
that, where S is your chief complaint. What is everything that's been the animal's problem? Then, as Sue said, assessment plan. If you have objective, great.
Yeah, some people do a subjective and an objective. That tends to kind of sometimes wiggle around in homeopathy land, and it doesn't necessarily matter if it does or doesn't. But I get lots of subjective stuff, and I get lots of objective stuff in the cases that I read, and I don't get very much assessment, and the plans are wishy-washy, So and even if your plan is, reduce the amount of meat or increase the vegetables to 1/3 of the total ration, whatever, because then you've got something and you know where it is. And that reminds me, and with that, I'll open it briefly to questions. But the other thing that I encourage folks to do is actually periodically have a discussion with folks about, what are you feeding? Like, not what are you supposed to be feeding, or what did we talk about feeding last year, but what are you actually feeding? And what supplements are you on? What other medications are you on? Because a lot of times you think you know, but you really don't know, and you get tricked or surprised. The other thing is, if you get in a situation with a case and you're really stuck, like I really don't know what's going on, certainly there's opportunity to consult with your colleagues and that sort of stuff. But sometimes one of the things that I find can be most useful is to actually just go back and retake the case, or retake a portion of the case. And that can be very, very, very helpful over time. Any particular comments, questions?
Yeah, I had one, and Laura had another. Laura said that unfortunately her computer mic isn't working, but she said, "Thank you. This is very helpful conversation." But referring to the diagnostic label, she said she uses that to communicate with the allopathic clinicians in the area and within the practice. Granted, stepping away from that is difficult at times, but it's very valuable as
Yes,
well.
yeah, I do. I don't, yes, I find that sometimes my medical language goes somewhere because I don't use it as frequently, because I don't
Mm.
use it with clients that often. Um, but yeah, that is useful. The other thing that I really make a point of is not using diagnostic labels with clients a lot. I really, I really go to, how did he show that? And I really don't like, his hip dysplasia, his heart failure, my migraines, because as soon as we identify that they're mine, oh my gosh, then they're possessive, and heaven forbid I would ever want to change that symptom because it's my symptom, or so the pain, the hip dysplasia, the whatever.
More important, I think, is the disease, because when you explain that it's the disease that your pet has,
Exactly.
and everything else is secondary, that's really all you have to do.
That's exactly. And folks catch on with that really. And
Mm,
I used to say, I don't care
that's
what you
right.
call it, let's call it Ralph.
Fred.
Yeah. And I say that to people, and it's just such a ridiculous thing to say, and then they go, "Oh, wait a minute. Yeah, let's do that." And it totally changes. It gets their focus off, Fifi's heat dysplasia, heart failure, seizures, blah 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 blah, and it's like, oh yeah, Fred, and folks are amazing. They're and sometimes you have to say something almost that ridiculous, like, let's call it Fred, and away we go. Anything else?
Nobody else, nothing from anyone else right now. I just want to add one thing to P. Your assessment plan, which you're right, is so important that people don't do enough of sometimes, is I found, and I know this is going to be a shocker to a lot of people, that clients, despite you make a simple recommendation, don't necessarily, especially if you're prescribing a remedy to someone who's never used a remedy before, and if you're doing a liquid, that's even more so. They don't always get it right.
Yeah.
They give the wrong remedy, they give it the wrong way. So what I found very useful is, in that plan, just write the email that you're going to send to the client with the plan, with the exact plan, whether it's change the
Right.
diet, go to the groomer, brush your dog more, give this remedy, whatever, and then
Right.
email that to the client.
I agree. I agree. And that, that's always part of if I see somebody in the office, that always goes home with somebody clearly, boom, boom, boom on the bottom of the records. I have a really interesting, I think, interesting medical record thing, because I found one of the things that I would fall behind on is like writing notes. So I have a really interesting medical record that's actually a checklist. And it follows after some of those old, medical arts press type checklist things, but it's much more developed than that. And so it gives folks it gives me a way to really write down physical exam findings quickly, and it gives folks the idea. They start to realize that we're looking at different things in a different way than they might ever have seen before. And I use it to grade things like dental tartar or redness of the gums. I use it for a lot of different ways. But what it did is it gave me a page where everything was there, and it was really quick to fill out. And so it saved the writing and the typing. But at the bottom of that page that's where the plans got written. And then I would take that sheet and flip it over if I had other clinical notes I wanted to write that the client would never get. But at the bottom, there's the plan. Same with the email to folks. I always send an email about prescribing, how to give remedies, that sort of thing. And I have a two-sided sheet I'm happy to share with people, that actually is a general philosophy thing that sort of summarizes everything, the philosophy about homeopathy stuff, all in one page, front and back. And I send that with people too, and it's very helpful for them to be reminded about unadulterated symptoms and those sorts of things. And I color code stuff, so I always send, you can say to people, it's coming in a blue, yeah, there's a remedy. You can redose it out of the blue bottle that I sent you last time. And, you'll see in your packet, there'll be a blue page that'll give you the instructions about how to give the medicine. And that is also really helpful, so it's not just one other piece of white paper that shows up in their physical box, if you're actually doing that sort of, in the clinic handout stuff and stuff. So I'm a real fanatic about color coding things, just because. Yeah.
Okay. Any other questions or comments? Eli, Karen, Laura, Noelle, Rachel, Stephanie, Jane, Sarah, anyone else? All right. Well, I don't see anything. Jane mentioned that clients often confuse common versus normal symptoms, and
Yes.
that's so
It's
important.
hugely, yeah, it's hugely, and clinicians probably do it just as
Yep.
often as
And you said it.
clients.
And breed normal.
Oh
Well,
my God. Yeah.
or cycling once a year. Yeah, that's
Yeah.
normal, really?
Yeah. And you'll
Eh,
find, the longer you row the homeopathy boat, you'll find stuff that it's not so, because we treat these animals and we see changes in them, and so now we're redoing stuff, redoing our assessment of the breed normal, or whatever it is that we're gonna talk about down the road. Yeah.
All right, so thank you, Dr. Beal.
Thank
That
you, guys.
was wonderful again. Thank you, everyone, for coming, and we'll see you in March.
Take care, guys. Have a
All right,
good.
good night. Thank you.
Yeah.
Happy Valentine's Day tomorrow.
Welcome.
Thanks. Bye.